So just moving on then, I've been in Canada now for close to 10 years, a bit over 10 years, and I spent a lot of time in my earlier career with the Australian Institute of Occupational Hygienists. So the AOH has over 1,000 members in Australia. They're the only occupational hygiene group in Australia, and they've done some really great work. And there's the person that I want to like you to listen to, Kate Cole. She's the president-elect, and she's done a phenomenal amount of work in Australia as a leader in this area. And so I just want people to look at her presentation and just think about what they've done. So.
Well, hi everyone, my name is Kate Cole. I'm the President-elect of the Australian Institute of Occupational Hygienists, and I'm going to give you a little bit of background about what's been happening in Australia during COVID-19. So I've been asked a few questions. The first is, can I explain my position in occupational hygiene, my role as President-elect of the Australian Institute of Occupational Hygienists, which we call the AIOH, and on behalf of the AIOH, what have we done to prevent COVID infection? So I'll start off at the beginning. As the President-elect of the AIOH, I basically support our current President, Dr. Ross DiColetto, before I become the President next year. Our mission at AIOH is a healthy working environment for all, and our objectives are to promote and improve the practice of occupational hygiene and the knowledge, competence and standing of occupational hygienists. We represent our profession nationally across Australia, and we aim to increase public awareness of the field of occupational hygiene and the importance of worker health protection. The AIOH sets standards for professional competence. We prepare and publish standards relating to the training of occupational hygienists, and we make representation on matters pertaining to occupational health. The AIOH and our members have been very busy during COVID-19 in supporting businesses to keep their workers safe. We have done a lot, but I might just highlight a few of the ways in which we've helped. Probably starting at the beginning, early in 2020, we were the first to raise the alarm in Australia on the importation and use of fake face masks in industry and in healthcare. We wrote and published a purchasing guide for businesses who needed to buy P2 N95 respiratory protection and help them discern fake from real masks. Pre-COVID, if you can remember that far back, we had been in the planning phases of launching Australia's first national respirator fit testing training and accreditation program. We recognised that there was a significant need to improve the competency of fit testers against both the Australian and international ISO respirator standards for fit testing, given the vast use of respiratory protection in industry. During COVID, the ResFit team really accelerated, and we launched the program more than 6 months early so that it could support our much needed healthcare sector. We also delivered many webinars and volunteered our time and expertise on numerous state and national task forces to improve Australia's response in the protection of workers from COVID-19 infection. So the next question I'm posed is, you've had a lead role and work in an Australian national advisory capacity. Can you explain what this advisory group does and your role within this group? In October 2020, the AIOH was invited to nominate a representative to join the Australian Commission on Safety and Quality in Healthcare National Clinical Task Force. The task force was established by the Commission to advise on the amendment of the previous 2017 National Safety and Quality Health Service Preventing and Controlling Healthcare Associated Infection Standard. We'll just call it the standard. I was nominated as the AIOH rep to that task force, and I promptly commenced working to review and improve that standard. The process for review was undertaken with particular reference to transmission-based precautions, environment and other controls in relation to SARS-CoV-2. And my role basically was to provide technical expertise in the field of occupational hygiene. In addition to that standard, I also volunteered my time on the National COVID-19 Clinical Evidence Task Force Infection Prevention and Control Panel. We'll call that the IPC panel. Following Victoria's second wave, our Federal Health Minister and the Australian Medical Association had announced a series of measures to reduce the number of healthcare worker infections. And one of those measures was the formation of a partnership between our National Infection Control Expert Group, which we call ICEG, and the National COVID-19 Evidence Task Force in the form of this IPC panel. That panel aimed to include broad clinical representation and experts with a diverse range of experience from various subspecialties, and I'm pleased to say one of them was occupational hygiene. For those that have read guidance published by ICEG during 2020, it's evident that advice on workplace safety was in great need of improvement. And so my aim of joining the IPC panel was to be able to effectively communicate the principles of occupational hygiene and to enable improved protection of healthcare workers from COVID-19 infection. So my last question is, can you tell me what has transpired since this work began and what the work and subsequent guidance material means to Australia and infection control moving forward? Well, the 2021 Preventing and Controlling Infections Standard was published on the 31st of May this year. The standard has been greatly improved to focus on worker health protection. Some key examples are recognition of the complementary relationship between healthcare worker safety and patient safety, the promotion of the hierarchy of controls to design infection prevention and control systems and programs, the promotion of a precautionary approach to transmission-based precautions, which is great. So, for example, in relation to COVID-19, infection is transmitted by aerosols, as we know, and we know that evidence continues to evolve. But in this standard, a precautionary approach involves the adoption of airborne precautions in situations where there is uncertainty about the type of circumstances that may arise in the care of a patient who is confirmed or suspected to have COVID-19. This means that healthcare workers would use a P2 N95 respirator in addition to other PPE that may be required as part of standard precautions to care for this type of patient. The standard also now requires consideration of ventilation and air management system issues and emerging evidence in relation to these issues as part of a precautionary approach to responding to the risk of airborne transmission of COVID-19. In Australia, all public and private hospitals, day procedure services and public dental practices are required to be accredited to this standard. And many other healthcare facilities will also choose to be accredited in order to improve the safety and quality of their healthcare provision. For the first time, these standards now include a focus on worker health protection nationally, which is a fantastic step forward for improving health and safety in the healthcare sector. With regards to the IPC panel work, over the last 7 months, we at the panel have met regularly and we've worked to document consensus guidelines on specific infection control issues that emerged during COVID-19. I'm pleased to say that the IPC panel consensus guideline has now been published just last week, and that has resulted in ICEG also updating their guidance. And I'm proud to say that significant improvements have been made, including recognising that particles up to 100 micron in size are able to be inhaled, so no magic 5 micron cutoff anymore. It recognises that fit testing has to be undertaken before first use of P2 N95 respirators. It recognises that all healthcare workers should have access to P2 N95 respirators, and it includes the provision of a risk-based approach to inform the use of PPE. So that's a really quick snapshot of what the AIOH has been doing in Australia. I hope you're all staying safe and you're staying well. And I very much look forward to the day that borders are open once again and we can meet face to face. Have a good day, everyone.
What a fantastic leader the AIOH has and Australia has. And, you know, we really need to leverage all this great work that's being done internationally. So when you listen to this, your recording as part of the bigger recording, I just want to thank you on behalf of everyone for sharing your recording with us. So thank you, Kate. Okay, our next speaker is Lawrence Zverchev, and I'm going to hand it over to you, Lawrence, now. Thank you.
Thank you very much, Kevin. I would just like to start out by welcoming we have with us a guest from Korea. I think it's about 3 a.m. in Korea, and this guest is Professor Jong-Young Park, from the International Occupational Hygiene Association. She's one of the leaders of the upcoming Korea conference. So welcome and thank you for joining us. Our topic today, myself and Vivian, is a zero COVID workplace infections, the necessary, reasonable, noble, and achievable goal. And in this course of this discussion, I'd like you to think big. So imagine that with no previous support or guidance from public health or government, how would you design your workplace COVID prevention plan? Is a necessary, reasonable, noble, and achievable goal to achieve zero infections possible in your workplace? Can it be done? So our goal today, myself and Vivian, is to provide you with some inspiration, data, and ideas to achieve zero infections from SARS-CoV-2 in the workplace. I'm going to be data-driven today. Canada, zero COVID-19 infections in a movie production. China, I'm going to address the first healthcare worker infections and mortality and the zero COVID-19 infections among 42,000 healthcare workers who responded to Wuhan. I'm going to address briefly infections at a remote iron mine site in Canada. And I'm also going to address infections among BC healthcare workers based on a research-based apologia. And an apologia is a classical term which essentially means a defense of the indefensible, an apology. Then I'm going to examine the international relative risk of COVID-19 by country, which is a calculation that Vivian and I have developed. The failures of rich Western countries, the successes of China and New Zealand, and I have to include in this Australia, but we do have the data on New Zealand. And finally, I'm going to briefly address the suppression mitigation strategy or the elimination strategy. I was privileged for 5 months to work as the COVID compliance officer on a TV series production. I have to put in a disclaimer, this is unpublished data and it's subject to confidentiality agreements. The condensation of the program and the analysis is solely on me. Our objective in this, and I'm not going to tell you, don't even ask who the stars were, what the name of the production was, etc. It's kind of immaterial. The objective of the program was to exclude the hazard, SARS-CoV-2, from the work site and meet the production schedule and budget. Again, this is my analysis. You won't read this if you ever get a hold of the original documents from the prime contractor. You're not going to see this kind of analysis. I'm putting the spin on it. So, step one, the international prime contractor, with the agreement of unions, sets out the occupational health and safety program and the specific expectations for each production. The film industry is highly unionized. So this step of including unions was essential, and the program would have been stalemated had it not had active participation of the unions and workers. The step two was the implementation at each production, including modifying scripting to meet COVID compliance, a contract with a certified PCR testing laboratory, and the installation of MERV 13 filters into the studio ventilation system. MERV filters are the high efficiency filters. PCR testing laboratory did the highest level of testing. The production duration was 5 months, September 2020 to January 2021. And there were approximately 500 workers per week. And when scenes involved extras or other contract workers, that 500 workers could be easily exceeded. So lots of action, lots of fun, and lots of issues to deal with. Here's a description of the workforce and its responsibilities. It's a large, unionized, highly intelligent, disciplined workforce that puts in long hours. We could be working 12 to 16 hours a day, 5 days a week, and sometimes into 16. We have what we call a hot set. That's the A zone. The folks in the PCR in the A zone were tested by PCR 2 times a week. And this would include the directors, the performers, sound, lighting, camera, hair, and makeup people. The B zone workers were tested weekly. Now, these are people who, when something is being filmed and recorded, there's moments, minutes, up to 15 minutes of intense actor, performer activity. So masks are off. When the assistant director yells, "What?" Masks go back on, and the B zone workers who were tested weekly would jump into the hot set zone, and they would do their work of rearranging the set, moving the cameras, moving the lighting, etc. C zone workers were not tested. These included drivers, food service people, carpenters, painters, set designers, and then we also had management. Doctor and nurse staff, COVID compliance officer, that happened to be me, and we were tested twice a week. We also had a COVID team. So these were B zone employees who deployed hand sanitizing stations, signage, the QR daily check-in, and things like that. And then we had the office and administrative staff. We had success factors, and I mainly want to talk about the success factors, not the negative parts. There was coherent planning and coordination between management, the creative people, namely the writers and the people who created the scripts, the COVID medical team, and the compliance teams. We worked really closely together. We had constant surveillance of the workforce. We had constant education and sympathetic listening by the nurses and the compliance officer. I worked together very closely with the nurses and the medical staff, and we would walk around the site together, fielding questions from workers. As you know, tons of false information floating around, tons of really good information, which is hard to interpret for most people. So professionals, nurses, myself, the doctor, and management, we tried our best to deal with these things. The management, creative teams, and workers had a common vision that SARS-CoV-2 could not enter the production. We didn't want a single infected worker. We didn't want a single case of SARS, of the virus entering our work site. I can say in direct and truthful words that the workers had a strong sense of social discipline. No worker wanted SARS-CoV-2 to enter the production or to take it home to their family. Our scariest period came over Christmas because we knew that they had become infected. I'm happy to report it didn't happen. We had one worker who was pretty much an extra, and she let her guard down. She got sick, and she immediately informed the production that she was under quarantine and could not come back to work. So not a single case of SARS-CoV-2 got into the production. So the results, 0 infections in 5 months. Production completed on time and budget. Principal lesson, 0 COVID-19 workplace infections can be achieved without a vaccine or pharmaceutical intervention. We call this an elimination strategy. Stop it in its tracks because we didn't have a vaccine to count on at that point. I'm going to now talk about the elimination strategy China style and state boldly, China was as surprised as Western countries by the power of SARS-CoV-2. China, the principal manufacturer of the world of N95 and Tyvek suits, ran out. The first few weeks, healthcare workers were working in adult diapers because they didn't have enough Tyvek suits. They couldn't take them off because if they took them off, they'd have to use another Tyvek suit to go back into the ward and take care of their patients. On April 16th, there was a webinar on the protection of healthcare workers with COVID-19 in COVID-19 lessons learned from China. And Professor Min Zhang, who is the head of the School of Public Health and the vice chair of the Chinese Occupational Health Standards Commission, revealed that by January 20th of 2020, which would be about 3 weeks after the crisis started, 15 healthcare workers had been infected, and this was the first evidence of human transmission of COVID-19 in China. On January 25th, the first healthcare worker fatality was confirmed. In other words, it took a bit of time to do the investigation and confirm that these things were happening. By February 14th, the National Health Commission revealed that 1,700 medical workers had been infected and 6 had died. And that is where slaughter stops, because China moves fast. China moves fast when there's this huge disaster. In the background, which we in the West would never have seen, plans were being put in place, and a total of 42,000 medical volunteers were deployed from all provinces in China to relieve the exhausted Wuhan healthcare workers. They rapidly developed a new administrative system in which local authorities were ordered to provide adequate rest, food, and PPE. Healthcare workers were qualified for COVID-related compensation, which they didn't have before. And that included support workers, home care workers, and even religious leaders. Astoundingly, in order to encourage a successful crushing and elimination of SARS-CoV-2, salaries for frontline medical workers were tripled. They developed new safe work procedures, including extensive training and a 27-step procedure for taking on and putting off PPE. And you're going to see some examples of PPE in a bit. They put together a supervisory and buddy system to ensure rigid adherence to infection control methods. And these healthcare workers went through constant nucleic acid testing. Objective: no patient can infect a healthcare worker, and no healthcare worker self-inoculates. The results are rather astounding and sometimes very difficult to believe. Infections and mortality for 42,000 medical volunteers was 0. Even if we build in some error, some poor reporting into this mechanism, this is an astounding achievement. And this was achieved without a vaccine. Vivian and I have reviewed a number of local hospital peer-reviewed publications and from hospitals that responded to Wuhan. And even though their workers came back COVID-free, the principal health issue became psychological trauma. I think we have something to learn from that. It's not discussed very much, and we're going to see it. We've already seen it, and we're going to see more. Vivian, would you like to take over for a moment and explain these photos?
Sure. Thank you, Lawrence. The following pictures show some moments when medical staff took protective measures against COVID-19 infection. This first picture shows that the trainer, because medical management institution in China at all levels have produced a lot of training videos on putting the PPE and taking off the PPE, and they deliver these videos to the medical staff in the fastest way, such as through social media platforms, WeChat or TikTok, etc. This is one of the videos. The trainers are demonstrating the steps of putting on and taking off the PPE with narration added. This is a standard image of medical workers wearing PPE, especially during the Wuhan outbreak at the beginning of last year. Some of my university classmates participated in the treatment at Leishanshan Hospital, which was the temporary hospital specialized in treating patients with COVID-19. They posted a lot of work photos in the group chat, all of which were of this image. Lawrence just said China also applied a buddy system to the implementation of PPE wearing system. So this is very important. This picture shows that medical workers check with each other whether the PPE is properly worn before going to work. This is also a step of the standard process. Outside medical facilities, when doing screening or the PCR testing on the work site, medical staff also follow similar PPE standards with coveralls, goggles, face shields, and gloves on, etc. Thank you.
I'd like to make two comments on these photos. The lower left-hand corner shows PAPR, powered air purifying respirators being used, which I don't think we see very much of in our medical system around Canada. On the right-hand photo, I do have a comment. Anytime I went to a lab for standard blood work during COVID, or even when I got my vaccine, medical workers, the healthcare workers, were not in any kind of protection like this. They were just in gloves and masks, surgical masks. Okay, next I would like to address, now that we have an understanding, a little bit of an understanding of healthcare response in China, I'd like to address a recent pre-publication, Protecting Healthcare Workers, Non-Pharmaceutical Interventions and Vaccine Effectiveness. A paper by Dr. Yassi, and it's pre-publication and very recent. And in spite of being pre-publication and not yet peer-reviewed and officially published, it has gained a significant following in media. Findings of this study, and it's fairly comprehensive, 3.3% of our healthcare workers became infected, mirroring community rates with a peak positivity of healthcare workers of 9.1% compared to 11.8%. As vaccine coverage increased, SARS-CoV-2 infections declined significantly in healthcare workers. The interpretation, predominantly droplet contact precautions with N95s required for aerosol generating medical procedures and available as needed to point of care risk assessment has been a highly effective approach to preventing occupational infection in healthcare workers. Now I'm going to address the points in yellow as we go a little bit later. Overall, this study indicates that excellent protection can be achieved with predominantly droplet infection prevention and control measures with N95s where appropriate. Data also includes this graph. Blue line is healthcare workers. So here's a peak of that line. And from this point forward, June, let's make it, let's be charitable, the middle of May to December 1st, December or so, very close parallel of healthcare worker infection with community. And then as vaccinations kick in, we see a disparity between community and healthcare workers. Now that would be expected. But back into a little bit of analysis. At this point, in British Columbia, we were seeing peak infection among healthcare workers. Guess what? China had already reduced COVID-19 to background noise. In other words, in my point of view, our healthcare system in Canada didn't absorb or pay attention to what was actually happening in China. Here's a table, and what I'd like you to do is pay attention to cumulative COVID-19 rates in percentages. So nurses, 3%, 3.2% infection rate. LPNs, licensed practical nurses and care aides, 5.2%. Medical staff, 2.1%. We had a total of 837 healthcare workers get infected. So ask yourself, which occupations are least likely to use respirators, N95s, in this list? yourself that question. And I'm going to say that LPNs and care aides, who are the least likely to use N95s, have the highest rate. Who are the care workers who are least likely to do a point of care risk assessment, even if it's a really good one? LPNs and care aides. Support staff. I can't think of a reason why support staff, namely administrative people, should have a 4.2 infection rate. So I call this the apologia, the defense of the indefensible. This is a false analysis. 3.3% of healthcare workers became infected, mirroring community rates. No, that doesn't compute. Among healthcare professionals, this rate should be approaching the achievable rate of 0. Gassi et al. Claimed that excellent protection can be achieved with predominantly droplet contact infection prevention and control measures. Again, no. That does not compute. The data indicate the strategy of not using N95 to protect healthcare workers is a disaster. The majority of 837 infections could have been prevented by using the more protective method of respirators rather than surgical masks and other methods which occupational hygienists are familiar with. Now, I'd like to briefly address the Mary River mine at, I cannot pronounce, and I really, Quiquetaluk region, Nunavut. There's an iron ore mine up in Mary River. Mine has about 1,000 workers. Air transportation is staged from Montreal up to this remote area. On April 19th, one worker tested positive shortly after arrival. Arrival is a key to this. On April 30th, there were 9 positive cases. On May 2nd, the mine suspended operation and multiple workers had flown out of the site, which has led to hundreds of cases across the entire country. There has been 1 death to date. Now, it's extremely difficult to obtain accurate and comprehensive data about the situation. So I've just picked this out of some of the media that I've seen to date. And as a fatalities investigator, as an accident investigator, I really don't want to jump to the conclusions too fast. But when we conduct investigations in occupational health and safety, we ask a lot of questions. My comment, occupational health and safety program does not appear to be designed to prevent SARS-CoV-2 from entering the site. Pre-flight PCR testing does not appear to have been considered. In other words, if PCR pre-flight testing had been done at the airport in the Montreal area, the virus would not have been transported by workers to the site. The Nunavut management, according to media, said that vaccination was left to workers visiting local clinics on their rotation, not as a condition of employment supplied by the company. Now, to my mind, a huge mining operation like this has almost infinite resources. If they had been thinking, perhaps quite a few months ago, their workers could have been vaccinated. Summary, the company appears to have relied on minimum standards, not the precautionary principle. I'm getting close to the end, and I'd like to demonstrate to you this slide from the World Health Organization. They issue epidemiological updates. And so now here you can see way back when. This is where the initial outbreak in China occurred and when it was stopped. A comprehensive look at this slide shows that this zone, which represents Europe, and the yellow zone, which represents the Americas, which is both North and South America, are the drivers of the pandemic until recently. In this slide, this part, the purple, represents recent data for mainly India. Vivian and I, we went to the World Health Organization data, and we did some calculations and rearranged World Health Organization data, and we calculated a relative risk of infection. If we take the global rate as 1, Our calculation shows that a relative risk for the major countries, the United States has 4.5 times per population rate of infection as the global average. Europe, 0.6 times. Have Canada in typically 0.6 times the national rate, 60% excess. Go down to the bottom of the scale. Here, 0.13 rate. Way, way below. We call this negligible. China, negligible. Vietnam, even though their rates are increasing recently due to the new variants, negligible through the entire course. Now, why is this? Some countries that stopped transmission without a vaccine worked on elimination strategy. That would be Korea, New Zealand, China, Vietnam, and others. There are people who say that, well, China has a draconian system, blah, 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 this type of stuff. As an occupational hygienist, I'm not concerned with that particular part. Because if we take a look at these 4 countries, each one has a different governance system. It has a different history, has a different culture. It has different geographic and hemispheric locations. The hemispheric locations tend to rule out seasonal differences. In other words, these countries had good leadership. They had a population that practiced social discipline, and they were able to overcome. Kevin, how am I doing for time?
I wanted to kind of save a little bit of room for questions at the end. We've got 10 minutes before the whole session closes out.
Okay, so then I'm going to the last slide, the hazard. The lessons of this is that the hazard is SARS-CoV-2. That's the hazard. Hazard's infectious dose is unknown, concentration cannot easily be measured, and it's carried in and out of the workplace by infected workers. Hazard should be treated as a biohazardous material, immediately dangerous to life and health. And the goal of the Occupational Health and Safety Program must be to eliminate the possibilities of the hazard entering the workplace. Thanks very much for listening.
Thanks so much, Lawrence and Vivian, just to give that really great international perspective. There was a question in the chat box from Kim, and we're occupational hygienists. We kind of just about every single presenter here is an occupational hygienist. So this actually relates to an occupational hygiene question. Now let me see if I can find it, the question. So it's from Kim Lan-Sir to everyone. Okay, so Kim Lan-Sir's question is, I think there needs to be consideration for those with an IH background, such as myself, but we don't do pure industrial hygiene work anymore. For example, sampling due to technology improvements. So where do we fit into this? Our work is more and more becoming a balance of doing environment, health, and safety. And I see Marc-Andre said that you could answer that question at the end. Did you want to kind of answer that question, Marc-Andre?
Certainly. It's my mind. It's something that I passed during the presentation, and I don't have a final answer. But I feel like this terminology of health and safety manager, for example, I think that's what she relates to. Like if she gets a job, she has more chance to have a job as a health and safety manager than as an occupational hygienist. And exactly, she says good. So my feeling is that we got stolen the health and safety terminology by the HR groups and a little bit by our safety colleagues. And I'll explain that. The first thing is EPA used to have an old definition that was making a clear difference between risk assessor and risk manager. And the difference is a risk assessor, he assesses the risk and says, from my perspective, you have that amount of risk, right? And the manager is the one that receives that information and decide what he's going to do with it, considering other factors that perhaps the risk assessor has not considered, things like budget, resources, and things like that. So that's the first thing. So you have to be careful about what's your role when you give an opinion. Are you being a risk assessor or are you being a risk manager? I found that these some positions, health and safety manager, you end up between the tree and the bark. You end up between two a rock and a hard places, you say in English. Being at the same time a manager and an assessor, and that's problematic. But historically, ILO has defined health and safety specialist, health and safety expert, and in their definition, they talk about physicians, they talk about occupational hygienists, and they talk about engineers. All careers that require high degree of education. Most people, if you look at the requirement to have a BCRSP, a safety professional, up to 2 years ago, it only requires a high school degree. And they updated it to a university degree, but in any field. All of this to say is that we have to recognize that health and safety historically has been an HR function. And this is where we get confused, is you're health and safety professional from a management perspective, or you are health and safety professional from a scientific perspective. And this is why I like so much the new branding of the American Industrial Hygiene Association that calls us occupational health and safety scientists. And it clearly sets us apart. Now, for the precise question about if you are the education from University of Toronto with Dr. Bozek, like you're qualified for ROH. And when you look at if you have a job that is health and safety, you need 50% of your time. You can stretch it because there is, if you look at the competency of an occupational hygienist, we have managerial skills that are one of the competencies, and you can use some of that in your work to make it 50%. So please, if you have an issue with setting your documentation to get your certification, I'm pretty sure that you would be competent.
Thanks very much, Marc-Andre. And I see Jonathan's still here. You know, we've all had kind of a lot of experiences as occupational hygienists, and, you know, what we do has kind of evolved. So, you know, along those kind of lines, Jonathan, would you kind of just share your thoughts about that, you know, as an occupational hygienist in our current position, you know? And to Dorothy's point, you know, Dorothy Wigmore she just doesn't go and suck air, like take samples. She does so much more. I just wondered, if, you know, for the other folks on the call, just to sort of share your thoughts in that area.
Yeah, I've mainly worked for labor unions in my career. And so my orientation was whatever the safety and health needs of the workforce are, I want to be able to help provide leadership. And the way that, you know, the main way that is accomplished, I think first base is workers have to have a voice. If workers don't have a voice, you don't get to first base. You don't really learn what they're going through in terms of the key hazards. Yeah, you can look at data, you can collect samples, but you need to have the knowledge directly from the workforce about the hazards and how they interact on the job and that type of thing. So, you know, I think the discipline of occupational hygiene is powerful because it teaches us to use science and evidence and how to research and put together programs. But I think, you know, we have to change with the times. And, you know, like in the US, we had 70% of jobs were in industry. Now it's less than 20%. So that doesn't mean that there aren't still hazardous working conditions. It just means that we have to shift to the industries that are experiencing the hazards and give power to the workers by constructing programs where they have an active role.
Thanks, Jonathan. So we're kind of coming to a close. I just wanted to provide just a couple of closing words here. You know, we've got to know each other pretty well, organizing this webinar. And, you know, our latest discussion was quite interesting. And we were talking about public health. You know, as occupational hygienists, we're part of public health. So we need to figure out how to not be marginalized anymore outside of public health and come back within the umbrella of public health and work more closely with public health scientists as well. And I don't know if anybody else wanted to just touch on that quickly. We've got a minute just with what I've said there. And we hopefully will run a webinar to that will cover that as well. Anybody just final thoughts there? Lawrence?
Yeah. On that comment, we started out as a profession, medical doctor. Primary historical influence comes from a woman called Dr. Alice Hamilton. And she's got a biography out there called The Hazardous Trades. And I'd recommend anybody to read it to see how we started and how this entrepreneurial doctor, at a time when women were not supposed to be, that women were supposed to be ladylike and not climb ladders in skirts in factories, she went and directly investigated. And she is one of the founders. It's dangerous trades. Second point is, when you become certified, you are now in an exclusive club, pretty much club. When I go to an employer and say I'm a certified industrial hygienist, and Marc Andre has very carefully articulated this, when you go to an employer and say, I'm peer reviewed in the profession, I'm qualified to do certain things. And the things that I don't know how to do, I have a network of people to go to. Respect from employers.
Okay, thanks.
We have to
Thanks,
transfer
Lawrence.
that into the public health. Thank you.
Yeah. Thanks, Lawrence, and thanks everyone. And I really very grateful to all of our speakers and for those of you that stuck around right till the end, and just to sharing your knowledge with us all. And so, Marc Andre, Lawrence, Jonathan, Vivian, over to you, Kate Cole. Thank you, and thanks everyone. So that's our webinar today. Thanks again.